Okay, I believe I am recording. Hey, this is Rebecca Heath. This is your first official lecture for the Winter 24 MedSurg 2 course. I have a little bit of a cold, so I apologize. My voice sounds a little uh, raspy, or if I have to cough or blow my nose. Speaking of that, let me close this little door here because you probably don't want to hear my laundry at this time. So we don't actually meet in person until the second week of classes, which is January 8th. So this first week, we're going to be focusing more on doing the assignments. I want you to watch this video, which we're going to cover more of the anatomy physiology. Chapter 36 really talks about data collection, reminding ourselves about the urinary and renal systems. If you watch this, it's really going to help you to be able to dive right in on week 2. Okay, so let's get going. So we have the urinary system. Let's see, I think we can present from here. Yeah, oh, okay, we did it. Look at that. All right, so learning outcomes. We want to talk about what's normal, right? If we know what's normal, we're going to be able to identify the abnormal when we see it. We want to know what's the normal function, what's the normal anatomy, what are some aging processes, because remember, aging is a normal process, but it does cause some abnormalities in our systems. And we also want to talk about what data we need to collect when we're looking at somebody who has a disorder, either of the urinary system or the renal system. I might use those terms interchangeably at times. Want to talk about how nursing is going to be assisting with procedures and preparation for those procedures with patients, planning for patients who have incontinence, and talking about nursing interactions, especially when we're talking about patients with urinary catheters. There's a lot of risks involved with that. Our big concept is going to be about elimination. So just some basics. Let's take it back to anatomy and physiology. You have 2 kidneys, which have 2 little tubes coming down from them that are called ureters. Those ureters lead into the one bladder. From that bladder, you have another little tube called a urethra that then empties out from your body. But I don't even have a picture of it. Okay, well, hold on just a second. Okay, I had to pause for a second because you need a picture of this. All right, so here you see we have 2 kidneys, and these little tubes, both on this side and this side, are called the ureters that lead down to the bladder, and then you have the urethra, and that's what empties out the bladder. So of course, women are going to have a urethra that's fairly short. Men are going to have a urethra that's a bit longer because they have a penis, and that extends the length of their urethra that they'll have. Let's get back in here. Okay, so the interior of the kidney. If you took a kidney and cut it in half, this is what it would look like over here. I'm not going to go through all of the different areas of the kidney and talk about each one of them in depth. If you're really curious or you don't remember, go through the book. It's got some good information on it. What I do want you to think about is the nephron. The nephron is the functional unit of the kidney. Each kidney has about 1 million of these in each kidney. So right now, if you have 2 kidneys, you probably have about 2 million nephrons in your body. And we use those because that's how the body does all these amazing things through the kidney. You can see how blood comes in, so you have little arrows, and goes through the cortex, and then it kind of travels all through these ways to filter out things. It's fascinating. Again, I'm not going to go through all the specifics. I just want you to know the nephron is kind of the main functional unit. So kidney function, what does it do? Which it also to me asks the question, why is it important, right? So the kidney forms urine, it excretes, and so part of that urine, we are excreting or conserving water. We're controlling our electrolyte balance. We're also controlling some acid-base balance. So if you remember some of the acid-base talk from last term in MedSurg 1, we're going to be building on that a little bit. It actually activates the production of vitamin D, produces erythropoietin, and produces renin. So you're going to hear a term called glomerular filtration rate. Sometimes, okay, I'm just gonna be real, almost all the time, you're gonna hear this shortened to be GFR. When people are wanting to know their patient's kidney function, they're going to say, what is their GFR? That's a pretty common term. And that just means it's how much the kidneys, how much filtrate or how much they produce in 1 minute. The average is about 100 to 125 milliliters per minute. And that's how, it's not actually, I say that wrong. It's not how much they produce, it's how much they can process or how much filtrate can go through the kidneys in a minute. So it's a really hard word. Glomerular filtration. It starts with that afferent arteriole in the nephron. We're not going to go through all of it, but you can kind of see, I like this picture here where it has this membrane where there's certain things that are going to be able to escape past those walls, while there's other things like your red blood cells and some other things that are going to be staying inside. Fun fact, the GFR, it's about 180 liters each day. So that's 60 times more than the blood's total volume, excuse me, which is really interesting. So your blood is cycled through your kidneys, almost 60 times a day. Like it's really incredible. Our kidneys are always really hard at work. So we talked a little bit about the ureters, the bladder, and the urethra. So let's talk a little bit about urine. Every one of you who's watching this has urinated, so you probably feel a little bit comfortable with knowing what urine is. So typically what we're going to see is about 1 to 2 liters or 1 to 2,000 milliliters every 24 hours. That's common production. Of course, that's going to change based on somebody's kidney function, their hydration status, and various other things, people's size, right? Children are much smaller than adults. So we're talking about adults with this number here. A child, because they have a smaller body, is going to be making less urine than that. Typical color would be pale yellow to amber. The appearance should be clear, that's normal. And specific gravity, 1.005 to 1.30, excuse me, 1.030. With specific gravity, I'm not going to ask you specific questions about, is this high or is this low? I really want you to know more about what they mean. Water, the specific gravity of water is 0. So our specific gravity of urine is a little bit higher than water, right? It's mostly fluid or excess water that our bodies are excreting, but there's also some other things in it. The lower the specific gravity is, the more diluted your urine is. The higher the specific gravity is of the urine, the more concentrated it is, meaning there's more particulates in it. There's more things inside of that fluid. The pH. So the pH of our urine is 4.5 to 8.0. That can range quite a bit. Your diet really affects that. This is really different than when we talked about our pH, when we talked about acid-base balance, the pH of our blood, right? The pH of our blood has a very, very narrow window. Anybody remember what our normal pH is in our blood? If you said 7.35 to 7.45, you get a gold star. Very good. The pH of our urine, quite a bit lower to a little bit higher than that. The constituents, or what our urine is made up of, 95% water. So much water. But there's also waste products, urea, creatinine, uric acid, anything extra our body kind of needs to get rid of will be in that urine. Sorry, I feel like I have glass shards in my throat right now. Okay, that was a little dramatic, but I'm giving myself a minute to be dramatic. So, aging and the urinary system. I like this map here, and if you can't see it very well, I really encourage you to look at it in your book because I feel like it really helps to break down the different changes that happen in the urinary system. And remember, these age-related changes are normal. We expect them to happen, but they are a dysfunction of the system. So let's start over here with females. Age-related changes. Pelvic floor muscles weaken. Well, why would that happen in women versus men? Right? Childbirth, right? Women, those who have had pregnancies, will have quite a bit of stress and strain on those pelvic muscles. Even women who haven't had childbirth, because of the function and the way that our bodies are designed, tend to have more pressure and issues with those pelvic floor muscles weakening. Females, as they get older, are also more prone to bladder infections, urinary incontinence, and then urethral irritation as well. Now, males, their issues are usually related to their prostate. As men get older, their prostates can often become enlarged. And I don't think I have the picture here. And we go over it more on the 8th. I think I've got good pictures. But when the prostate enlarges, it actually puts pressure on that urethra. So remember, the bladder has the urethra, which is the tube that you pee from. Prostate kind of surrounds that tube. So when the prostate's getting bigger, it pushes in on that tube. It makes it a lot more difficult to get that urine out through that tube, which causes difficulty voiding, which can lead to urinary retention or urine staying in the bladder. Now, some other age-related changes, stepping back, so male and female both, with the kidneys. There is a decreased ability to concentrate urine, meaning they're not going to be, they're kind of just peeing indiscriminately. They can't maybe retain some of the things they need to retain. Their number of nephrons decrease, right? Those are correlated. And their GFR decreases, that filtration rate. Remember we said about 60 times a day, the blood is getting circulated through. Well, that goes down quite a bit, that ability of the kidneys to filtrate. Because of these issues, it increases the risk of patients who are older. We give a lot of medications, right? Or other things that we call nephrotoxic um, um, items or medications. Sometimes it can be contrast dye. There are things that are nephrotoxic or they are toxic or could be harmful to the kidneys. Doesn't mean we're not going to give them to people. It just means, hey, we want to know if we want to like kind of gives us a clue to check our patient's kidney function. If we give our older patients some of these nephrotoxic agents, they could actually suffer more from those things. They might actually have harm to their kidneys. Moving on to the urinary bladder. So with age, there also is a decrease in their bladder size and the tone, especially the tone of the detrusor muscle. And that's the muscle that voiding. So when you are peeing, so when you pee, it is a voluntary response, right? When you are breathing, if you're sitting right now breathing, you are not actually usually thinking about it. You might start to think about it as we talk about it, but you're going to get distracted in a minute and your body is automatically going to take over that response and you are going to breathe automatically. Same thing with your heart. It is just beating regardless of what you do. You might influence it. You go run around the block, the heart rate's going to go up and you're laying down sleeping, it might go down. The urinary bladder, we actually have to make conscious effort to pee most of the time. And that effort, what we're controlling is the detrusor muscle. That's what actually opens up urine and lets it flow through and empty out. And so the tone of that detrusor muscle often deteriorates over age, which makes incontinence a lot more frequent. It also can have people causes urinary frequency, where they have to go more often. It could cause urinary retention, and then dysuria, kind of an issue with urinary issues overall. So we talked about this a little bit. It's kind of just continued of it. The renal mass, meaning their kidney mass, the size of it actually gets smaller with age. The blood flow or the flow through there decreases by about 50%. Basically everything, if you think about the kidney function, they work so hard. As you get older, all of that functionality decreases and gets a little bit slower. So kidney disease, when you have an issue with the kidneys, it really affects the rest of the body. When we have patients who are concerned that either have kidney disorders or they might have them, we want to get a pretty good health history. So what are the questions we're going to ask them? Well, one of the first things we're going to ask about pain or discomfort. That might be something that brings them in the flank area. When we say flank, I want you to put your hands on your hips and then just kind of rotate back a little bit, kind of right above your glute muscles, kind of off to the side. That's your flank. That is generally when people are having issues with their kidneys. I think especially about some renal stones or sometimes even infections, they're going to feel that pain there. That's where they will feel any issues. Patients might experience some a burning sensation when voiding. They might experience new onset of edema, shortness of breath, or weight gain. Okay, little question. What would that mean? All of a sudden they have edema, shortness of breath, and weight gain. Well, are they having too much fluid or not enough fluid? Right? That tells me there's too much fluid, right? So their kidneys probably aren't working very well. If they have too much fluid, they're not able to pee it out and it's backing up as edema in their legs or arms, wherever, shortness of breath, they might have fluid backing up in their lungs, and then that weight gain. We want to also ask about patients' fluid intake as well as their functional ability. We want to get their vital signs because with decreased kidney function or renal function, usually we retain more fluid, and that's going to cause our blood pressure to rise. When we have too much fluid in our system, especially thinking pulmonary, we might hear some crackles that can indicate a fluid overload. As well as edema or swelling, especially in our legs and feet, that can indicate a fluid overload as well. On our renal failure patients, we really want to get daily weights every day, weigh them. And the one thing about this is we want to make sure we're weighing them at the same time. You're going to get pretty vastly different numbers if you weigh somebody in the morning versus the afternoon or at night, right before a meal, right after. So typically, most places will weigh people first thing in the morning before they've eaten. We really want to get a good intake and output measurements on patients so that we know what's going in and what's coming out. Also, patients with kidney failure, they might have a little bit of a yellow or gray cast to their skin and can even develop a uremic frost. Here's a picture I pulled up from the internet. It just kind of looks a little bit crusty, almost like have you ever swam in the ocean and the water dries? It's kind of like the salty film that's left. It can look like that. So what are some tests we're going to do on our patients who have kidney issues? Well, a urinalysis. Sometimes this is called a UA, like urine analysis. Most of the time, we want to get the first void of the morning. If somebody is having sudden symptoms and we want to get a test right then, we might just go with whatever, but usually the first morning is the one you want to go with. You usually want to get either voided, and I don't remember if you guys have talked about specimen collection in lab yet, but you could just get random urine. If you're checking for infection, you really want to make sure that you have a clean catch urine specimen. And that's where you instruct the patients to clean themselves, men and women cleaning differently, of course. And then they start to void a little bit into the toilet, and then they would stop and then void into a little cup. About 10 mils is all we really need, not very much. And then they void the rest of the way. That's called a clean catch. When you get a urine specimen, you typically want to run your test on it within an hour or refrigerate it. After an hour, sitting out, it can start growing things that might not be truly indicative of what the patient has. So a composite urine specimen, or more commonly known as a 24-hour urine collection. This is really when we're looking at patients with renal function and really want to see, more than just that little picture of a one-time urine test. We want to say, hey, in 24 hours, what are they able to excrete? What does this all look like? So you start them at a very specific time. And it kind of always gets confusing with people about like, what are the timings with it? But let's say we have somebody, okay, it's 2 o'clock in the afternoon. We are going to start our urine collection. So at 2 o'clock, you go in, you have the person void, pee, and then you throw it away. And the reason why is you want everything, do you want to collect everything for 24 hours that person has made? And if it's already in their bladder, their kidneys already process that. So you're kind of like wiping the slate clean or emptying everything out at your start time. Now, the next time your patient pees after that start time, then you start collecting it. You collect it all the way through till the next day. So let's say 2 o'clock. It's 2 o'clock. You have them, oh, hey, Mr. Smith, it's 2 o'clock. You have them void. And then you do add that in. You count that as part of it because that was in our window of time. When you do 24-hour collections, you generally need to put it in a container from the lab. It has preservative agents or something in it, and then it generally has to be cooled or on ice. So you follow your facilities policy. If, let's say, maybe you go on break, somebody helps you out, and they're like, hey, Mr. Smith peed, I dumped his urine, it was 500. You go, oh, you dumped his urine, where did you put it? And they're like, oh, just down the toilet. And you're like, awesome, thank you for helping. He was on a 24-hour test. And so then you have to restart the whole thing. Usually that doesn't happen because if you would go into the bathroom, you would see like there's usually like a sign that says 24-hour collection. There's a big thing there. But just know, if you miss a void, if the patient voids in the bathroom, somebody dumps the urine in an accident, you just have to start the test all over again. Otherwise, you're not going to get accurate results. All right, so a urine culture. That identifies if there's any pathogens present, usually bacteria, sometimes yeast. It needs to be just like we talked about last term in MedSurg 1. Anytime you do a culture of any sort, you really want to make sure you get that culture before you give that person antibiotics. Otherwise, your culture is not going to be super accurate because those antibiotics, that medication, is going to be starting to work to decrease that bacteria in their system. So always, if you get an order for antibiotics, check. You have a culture you need to get first before you start the antibiotics. Most cultures will also have a sensitivity ordered, which means they're going to say, what medication are you sensitive? If there's a bacteria present, they're going to say what kills it the best, and are they on that medication? Now, you don't wait to start the antibiotics until you get the sensitivity. That takes a little bit. But what you might do is, you're giving them your azithromycin, whatever it is. And then you get their sensitivity back and it says, hey, it's really not sensitive to azithromycin. You'd want to give the provider a call so we can make sure they're on the correct antibiotic. All right, case study. I'm not going to read it because my voice kind of hurts. So I'm going to drink my coffee and let you read it. Okay, so we're preparing to give handoff report. Think about the information you want to share, and then you don't turn to your family, your friend, or your imaginary friend and give a little SBAR report. I'm going to go back to the case study. So go ahead and pause here and give your SBAR. All right, and here's the suggested answers. Our situation would be, we have Mr. Shea, 65-year-old male with flank pain, running a little bit of a fever with oliguria, history of diabetes and chronic kidney disease. Antibiotics were ordered. The urine specimen's already been collected, and I'm going to recommend starting our antibiotics. So continuing on with laboratory tests, we're going to do some renal function test that tells us how the kidneys are doing. There's going to be a blood urea nitrogen, serum creatinine, serum uric acid, the glomerular filtration rate, or GFR, and then a creatinine clearance test. Oh, we know this. You're caring for a patient that's having a 24-hour urine collection. The test began at 1 p.m. on Friday. It's now 1 p.m. on Saturday. What do we do? Well, if you said at that 1 p.m. 24-hour mark, you ask the patient to void and add that to collection container and then send it to the lab, you are 100% correct. Good job. So some procedures or tests that we might do with patients who have renal or kidney issues or urinary issues. Renal biopsy. Sometimes if we're looking at renal disease, trying to figure out what's going on with patients, occasionally for tumors, we might be getting a biopsy or kind of a collection of tissue. So a small section is obtained. It says through a flank incision. Most of the time it's going to be through a fine needle biopsy, meaning they'll look with an ultrasound or with a CT machine, CT scan, and they go in with a very tiny, as in the size around needle into the kidney tissue and take a very tiny piece of tissue. Usually not an actual incision that they open up, because the kidney is so vascular. You know, we talked about how frequently our blood is circulated through the kidneys. You know, if we poke them, they'll bleed. So if somebody has a tendency to bleed, we really want to kind of avoid doing this test unless truly necessary. If they have uncontrolled hypertension, they're going to have a lot of pressure, right? All that pressure, if somebody starts to bleed, it's kind of like a leak in a balloon. It's just going to keep going. Or if they have a solitary kidney, you know, most of us have two kidneys. Occasionally people are born with one. Occasionally there's one that's removed from illness or injury, or they've donated it. Sometimes you can have somebody that donates a kidney to another person to transplant. That might be a contraindication, because we really want to preserve their kidney function if at all possible. So the pre-care before somebody has one of these procedures, we want to make sure they're NPO, which is nothing to eat or drink, because they'll be giving a little bit of sedation. Afterwards, we want to really monitor that dressing. Sometimes patients will have to put a little bit of pressure on there or lay on the side where they had the biopsy. We're going to monitor their vital signs and we're going to be looking for bleeding. Some radiology studies we might have. We might get some x-rays that might tell us something about if there's a tumor. The kidneys are swollen. If there's maybe kidney stones, those will show up on x-rays. A pylogram, that's a pretty frequent test that's done, and that's imaging of the renal pelvis, calces, ureter. So there's a couple types. IV, and that's when they give contrast through an IV site and then do a bunch of x-rays to show as that IV contrast is cleared from the body through the kidneys. A retrograde pylogram is where they will insert a catheter, kind of like a Foley catheter, through the ureter, and they'll insert some contrast up through the kidneys. Antegrade pylogram, where they put a needle in and puncture kind of the kidneys, and they'll actually just directly inject some contrast in there. With the IV pylogram, that's probably a lot more common than the other ones. We really want to check for allergies. A lot of patients who are allergic to iodine can have a cross sensitivity to IV contrast. We also want to check to see what their creatinine is. That's going to give us an idea of how their kidney function does. Remember, we talked about there are some things that are nephrotoxic. So IV contrast can be nephrotoxic. And if somebody already has some impaired renal function, we want to be pretty careful with giving them a nephrotoxic agent. So typically, if they do have an elevated creatinine or we're worried about their kidneys, we would want to talk to the provider and make sure it's safe. With the IV pylogram, we really want to get them well hydrated both before and after the test so that we can clear that out of their system. So here's the IV pylogram. You can see that up here in the kidneys, they're starting to have some of that contrast, and it's getting filtered down into the bladder. So renal angiography, again, they're going to be giving a dye that goes into the blood, and it's going to show what the renal arteries, how they're perfusing. Really want to make sure anytime we're accessing people's arteries that we're checking their pulses as well, that we haven't caused any disruption in blood flow. So one thing that we get worried about with when we talk about our IV contrast being nephrotoxic is something called contrast-induced acute kidney injury. We already said that contrast can be nephrotoxic. So even if somebody doesn't have acute kidney injury, it actually can, or it doesn't have, they don't have kidney disease or kidney issues, giving somebody IV contrast can actually bump somebody into some renal failure. It might be acute renal failure. And remember, when we talk about word building, acute is like sudden, right now, whereas chronic would be the other part, and chronic would be long-term. It's usually slower and progressive. With this acute kidney injury, you're going to see a pretty sudden rise in their serum or blood creatinine levels. The patients are usually pretty asymptomatic. They're not showing any symptoms. Risk factors, somebody who has a lower GFR, especially if they have diabetes, and they also have nephrotoxic medications on board as well, right? Because it's kind of like adding insult to injury. They already have these medicines that can harm the kidneys, and all of a sudden we just give them this contrast that can also harm the kidneys, ends up overwhelming them, causing some injury. Very repairable, or most patients recover from acute kidney injury. But it's always nice to know if they have that in their past, because if you have somebody who's had acute kidney injury, it does mean they're at higher risk of having it again, or potentially developing chronic kidney failure, depending on their situation. So we're caring for a patient, so cue recognition. We're caring for a patient that has a decreased GFR, and they're taking metformin, and they're scheduled for a radiology test with contrast media. What do we do? All right, so if you don't know what metformin is, well, the first thing we're going to do is look up metformin, right? So metformin is a drug for people with diabetes. It works within the kidneys, and it also can be a bit nephrotoxic or harmful to the kidneys. If it's not functioning super well. So somebody, they're on metformin and they're going to go have some IV contrast. We are going to hold that metformin after the procedure. Now, are we just not going to give it? Well, yes, but we're going to get an official order from the provider, because we're going to say, hey, they had some IV contrast and they're on metformin. Do you want us to hold that? And the provider's going to go, oh yeah, thank you so much. No, we definitely don't want to give that. And most facilities are going to have policies regarding these type of things that will have, it'll be indicated for you, but just be aware, we want to be looking out for it. All right, endoscopic procedures, which means with a scope, pretty much. So cystoscopy and pylogram. So these are generally considered surgeries. There's no actual open incision, but it would be done in a surgery suite. And you would go in with, so female and male, it's the same type of procedure. It's just, like I said, the urethra is a little bit longer in males. You go in with a small tube that usually has a camera on it, as well as a opening where you can introduce in tiny little instruments. And so they can look at x-rays from the outside. They can, if there's a bladder tumor, they need to get a little biopsy. Sometimes they can put a stent in. There's all kinds of things they can do from these little tubes. After the procedure, they generally want to get x-rays again to see how things look. And we really want to look at the urine after surgery. Renal ultrasound is another test that's pretty commonly done. It's non-invasive, which is wonderful. It uses sound waves to look at anatomy. There's no special preparation. They don't have to be NPO or anything like that. It's really helpful to show if the kidneys are enlarged. It can show if there's kidney stones, chronic infections sometimes, or even tumors. Some of the nursing diagnosis for our diagnostic procedures might be anxiety, right? Patients might be nervous about it. They might have a deficit in knowledge, and we might actually have some impaired urinary elimination. Speaking of impaired urinary elimination, let's talk about incontinence. So stress incontinence. There's a few different types of incontinence. So we're just going to go through the different types. Stress incontinence, that's usually, it's an involuntary loss from increasing abdominal pressure. I typically, what you'll see is somebody sneezes, hashoo, and they pee a little bit. Again, this is more common usually in women than men, because women typically have that decrease of the muscle tone of their pelvic floor. Um, it can be caused from, like I said, coughing, sneezing, laughing, um, all kinds of different things, but that's stress incontinence. Urge incontinence is where somebody has the sensation of, I need to go to the bathroom, and right now it's happening. Most of us, we're sitting for a little bit, we're like, oh, I kind of have to go to the bathroom. We can wait for a while. Some of us a really long time, some of us not so long. People with urge incontinence, when they feel like they have to go, they run to the bathroom. Sometimes they can make it and sometimes they can't. That's urge incontinence. There's disability associated incontinence, and that's where it's not about the actual structures of the urinary system or the pelvic floor. It's more that they cannot get to the toilet. So they just end up having to pee because of their physical, mental, environmental barriers that they have. Overflow incontinence. This is where somebody's bladder gets over distended and full. And eventually, because if you think about the bladder like a balloon, it's going to get bigger and bigger and bigger. And eventually it has no more stretch left. And typically our bladder balloons don't pop, they just kind of overflow when we start peeing out. And then there's total incontinence. And that's where somebody has absolutely no control over when they pee or don't pee. If as any urine comes into the bladder, it's pretty much just coming right out. So some nursing diagnoses that are associated: stress incontinence, urge urinary incontinence, or disability associated incontinence. So when we talked about overflow incontinence, that's usually associated with urinary retention. Now, some of the causes can be acute versus happening right now, usually reversible, or chronic, which is progressive and getting worse over time. So acute causes, anesthesia, like having surgery, or certain medications. I think specifically about opiates, morphine, any of the oxycodone, things like that, they can cause urinary retention. We just can't pee out like you think you normally would be able to. Also, local trauma to the urinary structures. Chronic causes could be an enlarged prostate, like we talked about with men. Certain medications could cause this. Sometimes people can have strictures, especially in the urethra, or even tumors that are pushing in on that urethra. We really want to monitor. If somebody's having this type of incontinence, we want to monitor it. We really want to look at the bladder distension, and we're going to be doing bladder scans. Hopefully, most of you guys were able to do some bladder scanning in Clinical 1 last term. Most of the time, if you have anything from 100 to 200 milliliters left in the bladder, you want to report that. Each person is going to have different parameters, where for somebody that has maybe 250, that might be okay for one person. Another person, they might say, hey, we need to give a straight cath if it's over 200. So each person might have a different range, but we just want to know, if they're having bladder distension, we need to measure that and report it. So urinary catheters, there's a couple different kinds. We're going to talk about indwelling catheters. That's when they stay in. So a straight cath or an in and out catheter, right? That just goes in, collects urine, goes out, we're done. Indwelling is when it goes in and we leave it in for a time. And there are some justifiable reasons for somebody to have an indwelling catheter. Somebody who has severe burns, somebody who has a neurogenic bladder, they cannot pee, like that bladder just gets over distended all the time. Somebody who's in shock or has urinary tract obstruction. Those are all reasons we would have somebody have a urinary catheter. But urinary incontinence is not a justification, because evidence-based practice has shown that those catheters left in increase patients' risk of infection. So what we like to do is, if we can, if it's not an indicated reason, is that we might use intermittent catheterization, right? Somebody has, they just can't empty all the way. They're not able to void on their own very well. And so we might have intermittent catheterization. Patients sometimes will catheterize themselves. You might also have a suprapubic catheter, and that is where through it there's a surgical procedure done where there is usually underneath the belly button, but above the pubic bone, there's a small incision made where you will insert a catheter, or one will be inserted from that incision that goes directly into the bladder. And so you can empty the bladder that way. The suprapubic catheter is not one you generally want to go in and out of. There's going to always be a catheter there. But you do want to monitor the dressing, keep it clean and dry. Let's do a couple of review questions before we end. So the nurse is to administer an antibiotic and collect a urine specimen for culture and sensitivity. When do we administer the antibiotic? If you said 2, which is after collecting the urine specimen, you're correct. All right, number 2. Which of the following is post-procedure care? Oh my goodness, let's start again. Which of the following is post-procedure care for a renal biopsy, so kidney biopsy, the nurse should implement for a patient who's 54 years old and has family visitors? Select all that apply. Let's just go through these together. Monitor vital signs. Yeah, of course, right? Always. Observe for bleeding. Yeah, we talked about in a renal biopsy, there's a big risk of bleeding. Monitor the biopsy site. How else are we going to be monitoring for bleeding? Monitor urine output. Yeah, for sure. Maintaining NPO. Okay, let's think about that one. Do they need to be NPO before the procedure? Yes, because they get sedation. Do they need to be afterwards? No, they actually usually can eat and drink just fine. Let's check. 1, 2, 3, 4. Okay, we are correct. They don't have to be NPO. Everything else we want to do. High fives. Number 3, which of these patient statements does the nurse evaluate as having an understanding of stress incontinence? Okay, my voice is starting to really hurt. You read through these. We'll talk about it in a second. All right. Number 3, stress incontinence is involuntary urine loss from increasing abdominal pressure. Remember, sneezes, coughing, something like that. Number 4, the nurse reviews justifiable reasons for urinary catheterization for a patient. Which of these could apply? So what is a justifiable reason for urinary catheterization? Shock? Yeah, it is. Urinary tract obstruction? Yeah. Neurogenic bladder? Yep. Urinary incontinence? Mm-mm. Immobility? Mm-mm. Let's double check our answers. Yep. Wait, 2, 3, 4. What? Okay. The PowerPoint said shock, and I stand by it. So I'm just going to stand by it. And then 4, we don't keep a catheter in for urinary incontinence. Okay. This is just miscoded from the publisher. So the correct answers are 1, 2, 3. Boo, boo. Question number 5. The nurse is caring for a female patient, 43 years old, after a suprapubic catheter was inserted. What catheter care should we provide? Select all that apply. All right, let's go through this. Apply antibiotic ointment on the insertion site. What do you think? Only if ordered. Cleanse the site daily? Yeah, we would. Monitor the dressings? Of course. Monitor insertion site? Of course. Monitor urine output? Always. Secure the catheter? Indeed. Let's double check. 2, 3, 4, 5, 6. Yes, we don't do the antibiotic ointment unless it's ordered. That is the end. All right, let's get out of here. Let's stop sharing. Okay, well, hopefully this little, it's supposed to be a mini lecture. I feel like it's been like an hour. We've had a great time. Time flies when you're having fun. Hopefully this will prepare you well for our lecture on Tuesday. Believe it or not, I've missed you guys. I hope you've had a wonderful break, and we're gonna have a good time this term. We have a lot of good things to learn about. So I look forward to seeing you guys in class on the 8th. All right, bye.